Good evening, everyone. Last session, this is the second session we're going to have. The first session was Introduction to Palliative Care, which was taken by um, Smriti Rana, ma'am. So, today we have a faculty, Dr. Sanghamitra Bora. So, let me have the pleasure to introduce her. Um, she's a lead palliative care in Assam Cancer Care Foundation. She has completed her MSc Palliative Medicine from Cardiff University, UK in 2017. She's also a volunteer of Arujvin Healthcare Foundation, an active IEPC national faculty since 2010. She's also a national trainer for National Health System Resource Center and then Government of India. And she's also a very active member of various palliative associations and a close friend of Pallium India. So welcome, ma'am, for the session. So over to you, ma'am.
Thank you so much. Thank you for again for giving me this opportunity to interact with such a large group. I can see 57 participants, and that's really a great number. Congratulations to the whole team of Pallium India for spreading palliative care so nicely amongst those who would be torch bearers in the coming years. And I really feel privileged to be a part of this particular group. So I'm going to share my screen. Is this visible to everyone?
Yes, ma'am. Yes, ma'am. It's good.
Okay. So we'll be talking about palliative care delivery and interdisciplinary team. As I can assume, and as I know that many of you are perhaps working in the social work field and are inclined towards palliative care, and that is the reason why you are here. And having said this, I would like to mention the fact that volunteers and social workers are the backbone of a palliative care delivery system. Previously, we used to think, basically, when I am in the medical field, being a doctor, we used to think that maybe volunteers would be, functioning only in the community. But it's really not like that. I'm working for a cancer organization where we need volunteers and social workers every now and then. It's like we are unable to function without the help of a social worker or a volunteer. So, the volunteers and social workers and people from many other fields who actually come and contribute towards patient care, towards the ultimate delivery of palliative care treatment to those who need it. That particular team would actually make up a kind of a multidisciplinary team approach for such patients, whether they are in the community or whether they are in the hospital or, we need volunteers and social workers. And that is the reason why, we must, scientifically know where the volunteers and other professionals taking care of palliative care patients cross roads, and we need to pick up those important points so that we are able to deliver the care at our best. So talking about a team, because anyway, we cannot function without a team. We'll be just working in silos. So it's always good, always better to work inside a team so that you have people who are complementing each other's efforts to deliver the goal. So a team is basically a small number of people with complementary skills who are committed to a common purpose and performance goals and an approach for which they hold themselves mutually accountable. So this is a proper scientific definition of a team. Now, coming to an interdisciplinary team, so you can well gauge the word interdisciplinary, which means that, there would be many other people, joining together in one team and would be belonging to other disciplines. It is not necessarily that in a medical team, there are physicians, nurses, pharmacists, physiotherapists. But having said this, when you talk about interdisciplinary team, that means there are other people from other disciplines also. So interdisciplinary team basically are described as an identified collective in which the members would share common team goals and work independently in planning, problem solving, decision making, and implementing and evaluating the team related tasks. So basically a team of professionals coming together and forming, planning out their common goals of problem solving, and then making decisions, and then implementing and evaluating the tasks. So that is an interdisciplinary team. Now, what are the objectives of an interdisciplinary team? What should be the objectives of such a team? So there should be an accurate and speedy assessment. Okay, speedy because we'll have many other people, many other patients to attend to, and you want to efficiently work towards completing your tasks, your goal in a set time. Otherwise, you'll just have one patient a day and you'll not be able to cater to many other patients who would be in need for your work. Secondly, there should be an effective and integrated treatment and care. So efficient communication with the patient and the family, with other professionals, institutions, and within the teams itself, and the audit of the team's activities and outcomes. See, when you set your objectives of giving a particular care to a patient who is in need of palliative care. If I talk, specifically in terms of delivering palliative care for our patients, then you need to have an integrated treatment and care plan, okay? And which is absolutely effective. It is not like, you have integrated, you have planned out the treatment, you have planned the care process, but that is actually not culminating in some kind of benefit for the patient. This means that your care planning or your treatment planning is not effective. Okay. So, and when you talk about bringing about effectiveness into your care plan, the integral part that we all, as palliative care workers will understand is that we will have to have very good, efficient communication with the patient and the family. And not only the patient and family, it has to be with other professionals, other institutions, and within your team members also. Okay. And last but not the least, when you audit the team's activities and outcomes, you excel, day by day in your work, and you set better outcomes. Okay. So these are the objectives of an interdisciplinary team. So there are certain stages of team development. I'm sure you all must be knowing it, but I would like to just revisit all of it because, it's very important that we understand these stages. Because of the fact that whenever a team is formed, it is it goes through these natural processes, this natural process of development to get a mature team. And you will all appreciate the fact that unless and until we have a mature team, the team will not be able to develop, and the team will not be able to deliver the kind of service that it is required to deliver. So you can see there are two axes. One is the x-axis, another one is the y-axis, and both of them are plotted against the team effectiveness and time. So the effectiveness of a team over these, there are 5 stages, as you can see, and in these 5 stages, the effectiveness of the team varies according to the time taken to come from one stage to the other. So we will see how this works. So the first stage is called forming, the stage of forming. That means that the team members are coming together by virtue of your strategy or planning by the management or by your seniors who have actually, handpicked all of you and then asked you to come together. So in a palliative care team, we have a doctor, we have a nurse, and we also have a social worker. Sometimes we have a counselor. Many times, there'll be a physiotherapist, a volunteer. So everybody will come together, and this particular stage is called the stage of forming. And then, since all of us are naive to perhaps working in a team, we may have had experiences of working in other teams beforehand. But every time you join a new team, your team development will surely go through all these stages once again. Not because you have not been exposed to these stages before, or you may have had experiences of working in a team before. You may have been a very good team player, but that really doesn't define that this particular team formation will be fast and this will be accelerated. It has to go naturally through these processes. All right. So after coming together, the second stage that comes is the stage of storming. So what happens basically is there is a experience of conflicts between the team members. And why that happens, let me explain. So what happens is that, suppose I am a physician, I have been asked to join this particular palliative team. And there's this very experienced palliative care nurse who also comes and joins me. There's a social worker who has newly joined this organization and has been asked to be a part of the palliative care team. And other people, there would be perhaps a volunteer who says that I also want to be a part of this team. So we all come together, and the background that we have is that we want to do good to our patients. Okay, I, as a physician, I want to deliver the best possible treatment to my patient. The nurse would actually think that she would do her best to deliver the best nursing care to this patient. And similarly, for the social worker also, similarly for the, counselor also, or maybe the physiotherapist also. So there, there is a kind of a situation where everybody wants to give their best, and that actually leads to some kind of explosions inside the new team. So why these explosions happen? Because everybody is actually confined to their own goals and objectives. That doctor thinks that this is the best way that I can manage my patient. Okay. And I feel that this particular nurse who is in our team right now may not have had any experience working with such patients. Now, on the other hand, the nurse actually, thinks that, so this is a very young doctor, and, he has come from this particular place, and I wonder whether he has actually seen palliative care patients. I have been working since such a long time in palliative care. So, I believe that, unless and until we have a more experienced doctor in our team, the doctor may not be able to. So these kind of things actually go on at the back of their mind. Okay. And it is absolutely okay to have these thoughts. This is because of the fact that every individual, every participant in this particular team wants to give their best, right? And they think that their way of working is the best. All right. It's not anything related to selfishness or anything related to any kind of politics inside the team, but this is because it is out of the sentiment that they want to give their best for this particular patient. Now, here there are conflicting ideas. There would be, there'd be a kind of a depression where every team member would think that, oh my God, I think I'm in the wrong place, working for the wrong reasons. How can I actually adjust? This is becoming so terrible day by day. So this particular storming phase is something that actually, tries to, disturb the whole formation of the team. Okay. But then as time goes by, there is a kind of a stage where things start normalizing. Okay. And this stage of norming is actually understanding, the understanding by every member of the team of how to make things work. Okay, how are we all going to quarrel like this, or are we all going to live in conflicts? Every individual would think like that, and that makes them also think about bringing about solutions of how to make things work. So, the norming stage might be triggered by some kind of an incident. And that incident may be, a very critical patient in a, perhaps a critical patient in the community who needs your help as a team. And, for example, there's this very poor patient who is suffering from oral cancer and, bleeding all the time with a lot of pain and a lot of smell, and the family members are unable to take care of that patient. Okay, he's not able to eat, and you are now given that responsibility to go inside the community, find out this patient, and deliver your care. So how you do it when you are transitioning from the storming phase towards the norming phase. So you go as a team, and it is so automatic that you will never understand when things started normalizing for you. The doctor actually takes the role of his part to deliver, the best possible pain management for this patient. The nurse who's there would actually take the role of the best possible nursing care and jot down every issue that this patient is facing. Okay, the social worker would automatically go and interact with perhaps the neighbors or the family members, and then find out the issues that this particular family is facing and try to find out. And when they come back to to the office or to their own workplace, it's a very automatic thing that they sit together, they reflect back on what they have done for this particular patient, try to find out where they have gone wrong and what could have been done better. So this particular stage of norming starts with such kind of a trigger or such kind of an incident, and things start falling in place for every team member. And as time goes by, the understanding of team members increases, and they would actually transition to the stage of performing. And when you enter the stage of performing, you work effectively, you work efficiently, and you have set goals within the set time period. And that is, that is where you understand that the stages of team formation, was actually a kind of maturity being gained by a team. So I'm not going into the adjourning or disbanding the team, because that hardly happens. But then, the stages of team development is very, very important in palliative care, as in any other discipline also. But since as palliative care workers, we are always working in interdisciplinary teams. We feel really paralyzed when my nurse doesn't come a day, or somebody else is missing from the team. There is no volunteer. So we really feel paralyzed. So it's very important to understand, the importance of a team, the development of a team, and how you can sustain on the performing stage. Okay, so you can also see the team effectiveness in this blue graph. Blue line actually shows you that when you come together, when the team is in the stage forming stage, the effectiveness of the team slowly, gradually declines, entering the storming where it is the lowest, and then while normalizing and performing, the whole effectiveness, team effectiveness gradually increases. So this is all about the stage of team development. So what are the characteristics of an effective teamwork? What should you be looking at? So there are three ledges, as I would say, and they are: one is the organizational structure, secondly, it is the individual contribution towards the team, and then the team process. Okay, so when you are working in an organization, always remember that you are a part of a larger team. Okay, and that particular team of the organization, you may not be interacting with every individual at every point of time. It may not be like that. But always remember that you are a part of a larger organizational structure, larger team, which is the organization. So an organization, as an organization, there is a clear purpose, there is an appropriate culture being laid down, there are specified tasks, okay? And when we say specified tasks, the medical team would have different tasks. The management team will have different tasks. The education team will have different tasks. So, but then all of them are actually interlinked, okay? And all of them will have one clear purpose and one goal, okay? So it's like one team and one goal. Every individual in the organization will have distinct roles. There would be a suitable leadership. Always remember, in a team, there is always a natural leader, okay? But when you work in an organization, it is always the hierarchy that counts, and that is the one which is actually going to give you your purpose and your tasks and roles. And then, of course, we are all relevant members of this organization, and we would look into adequate resources for our work to be fulfilled, our goals to be fulfilled. An individual's contribution in the organization is an extremely important thing. It's like the building block. So self-knowledge, trust, commitment, and flexibility. These 4 characteristics generally comes from an individual, okay? And if you have somebody who's knowledgeable, who's trustworthy, who's as committed to palliative care as any other individual, and who's also flexible while working in certain conditions. For example, my nurse didn't come today, so I hire somebody else from another team, and I request her to do an overtime. Her flexibility of time would actually give us an advantage to fulfill our own goals, okay? So individual contribution is extremely important in an effective teamwork. And then the team processes, there should be coordination, there should be a lot of communication, a cohesive structure, a cohesive bonding between each team member, and then decision making, conflict management, social relationships, performance feedback, everything would actually fall in place, would be followed properly if individual contributions and organizational structures are in place. So we talk about the palliative care team now, and that is what the whole talk, today's discussion is all about. So bigger palliative care organizations, you'll find everybody is working in a team, okay? Essentially, an interdisciplinary team is the backbone of a palliative care team, and it has its own characteristics and challenges, okay? The palliative care interdisciplinary team should both be defined and flexible. And when I say defined, I mean that who are the team members of an interdisciplinary team? What are their, set goals? Are they complementing each other in a way so that the larger goal of the palliative care team is met? And are these team members flexible enough to, reach that particular goal? So that is the meaning of a palliative care interdisciplinary team being defined and flexible. So the core team can always be a physician and nurses. They are the essential members of a palliative care team. But having said this, a social worker, a pastoral worker, chaplain, a therapist, of any discipline, a physiotherapist, an acupuncturist, everybody can also be the essential members of this particular core team. But of course, that would depend on their availability and other resources. An extended team of a palliative care team can consist of a psychologist. There can be a physiotherapist, an occupational therapist. There can be a dietitian or a nutritionist, specialist palliative care providers like an oncologist, somebody from the neurology department, a respiratory specialist, cardiac or nephrologist also. Okay, so extended, generally, the medical teams of from oncology, nephrology, etc., they are considered to be a multidisciplinary team. But having said this, when the core team is of palliative care and you want these other disciplines to come in, you are actually extending your palliative care team. Okay, but the interdisciplinary team would always remain the core team. Now, the most important question that we are facing is, will you consider the patient and the family members, the members of the team, of this particular team or not? So we need to understand few things. That firstly, palliative medicine or palliative care is always patient-centric. Okay, always patient-centric. The core of the whole process, the patient is at the core. Okay, all treatments, they have to be given with the patient's consent and in accordance with his or her wishes. All right. So when we are focusing on the patient's consent and patient wishes will have to be taken into complete consideration. The patient must be considered the part of the team. And this is the reason why a patient is at the core of a palliative care team. Okay, if the patient is unconscious, or patient is not able to comprehend the work of the team, then there would be a surrogate. There would be somebody to represent the patient, and that is the reason why family members have an important role in the overall care of the patient. Okay, suppose the patient is you start the palliative care process or treatment for a particular patient who is, perhaps in the terminal stage, but not imminently dying. Okay, so the patient's treatment options have exhausted, and the doctors of this specialty have actually, told about the prognosis being bad for the patient, and that the patient may not be living for another 12 months. And that is the reason why the palliative care team is contacted, and this particular patient is presently, will be taken care by the palliative care people. Now, the patient doesn't have any signs and symptoms of imminently dying. Okay, the patient is absolutely fine. Patient is working. Patient is eating properly. The only fact is that the prognosis, according to the reports, according to the parameters, biological parameters, the patient is gradually, deteriorating. Okay, and at one point of time, the patient may, slip into coma. Patient may not be able to comprehend what is happening. Patient may become unconscious. But when the patient actually comes to the palliative care team, the patient becomes part of the palliative care team. Okay, so whatever decision we take for the patient has to we have to have the consent of the patient. We have to have the patient in agreement with that particular care process. Okay, so while formulating a treatment plan and a care plan, the family members and the patient also need to be considered. And that is the reason why the patient and family members are a part of the palliative care team. As you must have understood by now that interdisciplinary team members can be many, the core members being the doctors, nurses. The other members would actually be the chaplains, occupational therapists, music therapist. Very interestingly, music therapy is so developed in the West. It is, I've seen examples, I've read certain scientific papers about how music therapy brings about a change, brings about a lot of positivity in terms. Okay, so, we must consider people who do music therapy, to be a part of our team. Okay, physiotherapist, you can never ever, actually, leave aside physiotherapist and work. You need physiotherapy for everybody, for every patient, whether he is terminal, he is, having a surgery, a simple hip joint surgery, whatever, you need a physiotherapist. And then last but not the least, a dietitian and a nutritionist. Oh my God, they're so helpful. And, once they understand the essence of palliative care, the kind of contributions that they give for these patients are absolutely unbelievable. Coming to where are the places or settings where you can deliver palliative care. Okay, so you can do it anywhere that you wish, and anywhere where the patient wishes, actually. Okay, you can do it at home. There can be an outpatient facility, a daycare center, an acute care center also. And then, of course, there are specialist palliative care units all over the country today. In bigger hospitals, they have specialist palliative care units. And then you must be all knowing about the hospices. So we'll talk about home care teams now. Generally, they provide specialist advice and they work alongside the community person. It's impossible for a home care team to work, without the people from the community helping them. Okay, when you as a home care team, you go to a patient's home, there would be neighbors. If it is a village, the village headman, will be one of the very important resources. I remember here in Assam, when we do home care in suburbs, in the suburban areas, there are school teachers, or there are school headmasters who actually come and offer so much of help for such kind of patients who are there. So we as home care teams must also be able to take advantage of their presence, of their expertise, which we are actually getting for free. Okay, they're not demanding anything. They have just come out to help us help this particular patient. Okay, so they will be in contact with so many influential people. There'll be many, they would be knowing about so many resources from where they can actually bring something for this particular patient and help him. Okay, so it's very important that home care teams work alongside the community people. Okay, they can be volunteers, as I said, social workers. They can be local general practitioners. Local general practitioners are so very important. Okay, we cannot actually work without local general practitioners. I'll tell you, small incident where we had just visited a terminal patient and come back, and at around 12:30 in the night, I got a call from the neighbor that this patient is actually perhaps going to die. He's having the gasping kind of a thing, which we consider as the last breath. So, it was impossible for me to go and attend. And the only thing that bothered me was who's going to give a death certificate for this particular patient. So, it was so good that during our visit as a team, we got to, got introduced to one of these general practitioners who practices nearby and has offered to help this patient. And at one call, he actually went to this patient's home. He stayed there till the patient died. Of course, we were also on the call, and he helped them get a death certificate. Otherwise, there would be many reluctance on general practitioners unless they understand what is what the essence of providing such a care to terminal patients. They would actually be very reluctant to provide with death certificates. So, it's important for home care teams to also gel well with local general practitioners. And then the community workers who would generally coordinate the care of patients, and then they form a bridge between the specialist palliative care team and the home care team. So these things are very, very important when you also form your home care team. You cannot work in silos. You have to have your communications right and your gelling ability up to the standard in order to
excuse me, ma'am.
yes.
Yes, ma'am. Sorry to interrupt, but we have a question in the chat box from Saliha Afreen. What about psychologists and their role in IDT?
Yeah, so as I think I have already showed that slide. Let me just go back and I'll tell you. So here you can see the core team of a interdisciplinary team. When I say interdisciplinary team, it means the most important people that are always required. Okay, and you can define your interdisciplinary team by yourself, and you can define your core team all by yourself. For me, for many other people, a physician and a nurse would actually define the core team. Okay, and you can keep on adding other people as the need be. Okay, and for that reason, you can put in a chaplain, you can put in a social worker. You can also put in a psychologist. That is absolutely up to you. Okay, but we would generally, require a psychologist's help in the extended team of the core team. Okay, every time a psychologist may not be needed to go to that particular patient's home. Okay, But then if the psychologist volunteers that no, I would want to be a part of this core team, that psychologist is most welcome to join. Okay. This I am saying because, there's a dearth of psychologists. There's a dearth of physiotherapists. Okay. And even dietitians and nutritionists and people who are specialized in palliative care. Okay. And if you have a psychologist, most welcome. There are many social workers who have done their degrees in psychology, and they have also given their expertise as psychologists also. Okay. There are many nurses who have adopted many psychological practices, and they also provide some kind of psychological help. All right. Physicians are also trained in psychology, and if they are interested, they can also contribute towards taking care of the psychological part. But having said this, I would actually say that every team is defined by their own characteristics. They are defined by their own challenges. For example, if we have a psychologist, we do not have a nurse at all, then maybe we will actually try to try to teach the psychologist to do some bit of nursing. Okay. The physician might also do some bit of nursing care. All right. But if there is a nurse, there is a physician, and there is a psychologist, we do not have a social worker, then the psychologist is actually one of the team members of this particular interdisciplinary team. Okay. So you can define your team all by yourself. There's no stopping to it. Okay. You may actually keep on adding other therapists, other people. But having said this, when we say interdisciplinary team, we do mean a smaller team, so that we do not have much of the storming phase. Am I clear in that? Did I answer your question?
Yes, I think she has said thanks for the clarity.
Okay.
Yes, ma'am. Yeah.
Okay, thank you. All right. So, yeah. So we were talking about the home care teams. So when we talk about home care teams, we need to understand what are the advantages and disadvantages of providing home care. Okay. It is not always very rosy and cozy. So you'll need to understand the advantages and disadvantages also. So there are studies that indicate that more than 70% of our patients prefer to die at home. All right. That is the reason why, for such patients, those patients who want to die at home care is the best form of care. There would be more autonomy, there would be privacy, there would be more freedom, and patients would feel safer at home. Families can anticipate the loss. They can have a better bereavement stage. They can accept death as a normal process of life. Okay. It also reduces the cost of care. It prevents unnecessary hospitalizations. Okay. But we need to also see what are the disadvantages. Now, palliative care may also be difficult or impossible if it is against the patient's wish. So, we were talking about the principles of palliative care ethics. And when it comes to patient's wish, patient's autonomy, it is very important that we give a preference to his wish. Okay. If the patient says that I don't want to live at home, I want to go to the hospital, and the doctors are free to do whatever they want to, but I really do not want to come back home and die. Okay. So their wish needs to be fulfilled. Okay. And there would be many patients, many people who might be living alone. Okay. And they might be living very far from the palliative care facility, or they might be living in a place where the home care team just cannot reach them. Okay. It might be like in a very interior place. Okay. So, and there would be other patients who might need a very high skilled care. For example, a patient with intractable breathing difficulty. Okay. There are many patients who suffer from lung cancer and they have very bad, difficult breathing problems. And it becomes very difficult for people, for home care team to take proper care at home. Okay. They would be needing oxygen, they would be needing certain injectable medications, they would be needing many other things which may not be possible inside a patient's home. Secondly, family is physically or emotionally tired. Okay. This is a very, very important reason in a nuclear family. The wife is also working, the husband is also working, the children go to school, and there is nobody to look after the elderly patient who is perhaps a terminal patient. Okay. The wife has to, bring medications. The wife has to coordinate with the doctor. The wife has to look after kids. The wife has to, look after the patient. And at the last, she's absolutely drained out of all her energy and she just cannot make it. Okay. So it is difficult for the family physically or emotionally to take care of such patients. Okay. And they are unable to deal with uncontrolled symptoms. Okay. The patient is always crying in severe pain, even if they have been given proper medications for unknown reasons. There is uncontrolled symptoms. Okay. They are unable to meet with minimal comfort needs. So such kind of patients, home care.
I think ma'am's internet connection has got some problem. Ma'am.
Hello?
Yes, ma'am. Yes, ma'am. Now it's fine. I think it got stuck.
Okay.
Yeah.
Yeah. A little bit of disturbance, but I hope you can now.
Yes,
Hello?
ma'am. Yes, ma'am. Sure. Yes, we are able to hear you. Yes, ma'am.
So, these are pictures of some home care teams, providing some help to these patients. We come to the outpatient facility where, they also have their own set of advantages and disadvantages. So patient can have a consultation from a multidisciplinary team. Patient can, the family meetings, counseling, support group activities, they all can happen in the same place. Okay. It can be done in the outpatient facility. And in case of very severely symptomatic patients, a daycare symptom control can be easily arranged. So in an outpatient facility, you can actually, the patient can spend the whole day and, get all the consultations done in under one roof. And then, he can go back home. Okay. There can be many other doctors from other disciplines who can come and see the patient, or the patient can be taken to those doctors, have a round of consultation and come back. But the disadvantages being that the patient may have to long wait, have to wait in long queues in the OPDs, as it is a common scenario in many of bigger hospitals, in our government hospitals. Okay. In bigger cancer hospitals also, you have to wait for a very long period of time. And then space issues. We are anyway short of space in every facility. A severely symptomatic patient may require a more comfortable space, which you may not be able to provide for that particular patient at that particular point of time. And then consultants from all the disciplines, they may not be available on the same day. So the patient may be required to have repeated visits, okay, which may not be possible for that particular patient. And very sick patients may not actually make it to the outpatient facility. Daycare centers, you can provide good palliative care support to in your daycare centers. The advantages being is that symptom control can be easily achieved by keeping the patient under close monitoring. At least, for 6 hours, you keep the patient under close monitoring. The patient can go home after a short day course of medications or interventions like blood transfusions, fluid replacements. Many a time we do, IV morphine trial and then titrate the morphine dose for such patients. The patient becomes pain-free and goes back home nicely. But having said this, it may not be a very cost-effective option for patients. It might actually be quite costly. And then the treating team may admit only those who are not in the end of life. That might be a kind of a policy matter for that particular hospital. And this may result in frustration of the patients or relatives. There are acute care facilities like the intensive care units where patients are kept. Basically, the neurological patients like semi and unconscious patients, acute breathlessness patients, neurosurgical patients, those are kept in the intensive care units, and you can provide intensive care, intensive palliative care for such patients, and that is provided as an adjunct to the main specialty. Specialist palliative care units are a distinct type of unit, and they are designated for terminally ill patients who require intensive involvement of a specialist ITD and to be able to manage their complex problems. Okay. All members are exclusively trained in specialized palliative care. They function as an inpatient stabilization unit only. Okay. And then they manage all the uncontrolled symptoms at the end of life also. Hospice, you already know, it ensures the best quality of life and the best quality of death for our patients. Generally, patients with a minimum prognosis of 6 months are admitted for hospice care. And this is because of the principle of hospice care that is being laid down. The intensive acute care is generally not provided to such patients. They are also not, referred for further chemotherapy or radiotherapy or any other surgery. That is like no definitive treatment is given. They are just kept in the hospice for comfort care and, like they would generally patients come and they live till they die in the hospice. So there are many hospices now in India. The first hospice that was established was the Shanti Vedna Hospice in Mumbai. One of these branches are also in Delhi. Those from Delhi, they would know that it is just near Safdarjung Hospital. A Sacred Heart Palliative Care Center is the only hospice here in Assam, in Guwahati, and other hospices that have now started to come up is the Karunashra Hospice in Bangalore. There is a hospice, another one hospice in Chennai, and I think there are such facilities being developed throughout the country now. So with this, we come to the most important part that we shouldn't be, lagging behind, and that is the social work in palliative care. So, social work is, it's a very huge kind of a vague kind of a term. Okay, many people say I'm doing social work. I went to the elderly facility today and I donated so I'm doing social work. Okay. I went to this orphanage and I donated so much of money and new clothes and new toys for these children. So I am a social worker. This is not social work at all. This is contributing towards a social cause. It cannot be defined as social work. So the role of a social worker has a different shape altogether. Okay. So there are three forces that shape the social work role. Number one, the non-medical social goals. Okay. Secondly, the teamwork and multi-professional skills required to meet these non-medical goals. And the third one is the expectations of patients, the carers, relatives, friends, various palliative care professionals, including the social workers. So these are the three forces, actually. They force to shape the social work role in palliative care. All right. So the non-medical social goals are expressing emotional pain. Okay. Why this is inside a non-medical social goal? This is because of the fact that of the saying that doctors are emotionless people. Can you relate to this particular thing? So, if you have seen that movie, Munna Bhai MBBS, you can see the main, the dean of that particular hospital, played by Boman Irani. What he says, if you love your daughter, you cannot operate on her, right? And that is the reason why you should not fall in love with your patients. Okay, so this particular emotional pain, okay, has to be taken out. Okay, there is an emotional pain inside every person, every professional. All right, and that needs to be expressed, and that is where the non-medical social goal of expressing emotional pain comes into play in a social worker's shape, in a social worker's role. Okay, the need for exploration of spiritual pain. Similarly, as emotional pain, the exploration of spiritual pain and the need for practical help, where you can find practical help when you actually while you take care of emotional pain as well as the spiritual pain. Okay. So what are the perspectives of the social worker? Number one, the social worker has to find out what he or she cannot do. Okay, he cannot cure pain. He is not able to dress bad wounds until and unless he has a interest in doing that, and then he is unable to offer appropriate religious rituals. Okay. Secondly, to see the patient as part of the family and social network, and that is not only the perspective of the social worker, it is the perspective of the IDT as a whole. Thirdly, to understand the implications of special situations for the patient. For example, the mental health legislation. Social workers are so important to understand and make his team members understand about mental health legislation. Okay. For example, there is a patient who's a psychiatric patient, and this particular patient is undergoing a terminal illness. What are the rules and regulations of the country? What is the law that that legislates the mental health conditions of such patient? What are the advantages that these patients would have over other patients? What are the different schemes that are applicable for such patients? Okay, these things are to be looked after by the social worker. So mainly there are 4 areas of social work. Firstly, a proper assessment, then designing an intervention. After assessing the patient, you design an intervention, and then bereavement support. Once the patient is dead, once the patient goes away, passes away, you will also need to design the bereavement support. Whether this bereavement is a simple bereavement or is it going to be a long, complex bereavement. Okay. And then wider roles when you communicate and collaborate and coordinate with the community for this particular patient of that particular community. Okay. So these 4 areas, main areas of social work needs to be understood. When we come to an assessment, assessment is done on 4 particular pillars. Firstly, the emotional pillar, the social pillar, the practical, and the financial pillar. Financial pillar assessment is extremely important in social work. Okay, many of our social workers who's working with us presently, they have helped our poor patients so much with so many schemes that the government has. The government brings about a lot of schemes to help the public, but the people are not aware of it. Okay, they do not know where to go. They just do not know how to navigate that. And that is actually done by our social workers. Okay, there is always a need to identify any further assessment that is required. The social worker also coordinates between disciplines. That is also very important. The oncology team and the palliative care team, may not have that particular coordination unless and until the bridge is actually built by the social worker. Okay, because the social worker would help a patient who's under oncology and is recovering. And the social worker is also part of the palliative care team who is actually looking after the terminal patients. So both the coordination between both these 2 specialties is brought about by the common social worker. Then the need for a specialist help, as it is understood, and assessment at 4 levels, as I said, the individual, family, physical resources, and the social resources. Interventions, these are aimed at patients and families in need of help to cope with others, with their situations. There should be a provision of adequate and appropriate information, facilitating proper communication to reach a solution, imbibing the confidence to act, facilitating the required resources, facilitating bereavement support. Something about bereavement also. Social workers, they give one-to-one bereavement support. For example, if there is a patient and the patient was a parent of a young daughter and she has passed away, the daughter is left alone. that particular girl would need a one-to-one bereavement support. And you never know that this girl might be so comfortable talking to the social worker rather than other team members of the palliative care team. Okay, so one-to-one bereavement support is provided in a very nice manner by the social worker. Bereavement groups, when needed, they facilitate bereavement groups, bereavement counseling, extended grief counseling, and special needs. For example, loss of a child, loss of a young adult. All these groups will need, a proper bereavement support. On a wider role, social workers do internal consultancy, for example, supporting doctors and nurses to carry out the social work task. For example, the doctors and nurses are actually not, they do not generally fit into the social work role, okay? But by virtue of the social worker present in the team, they are also able to carry out the social work task, okay? That particular task might extend from simple advice to a leadership role in the interdisciplinary team. Social workers should also be involved in a day-to-day decisions on management of patients. They respond to suicide threats, deciding facilities for child patients, etc., and then working with interpreters also. Okay, so during the COVID times, when many Bihari workers had gone to Kerala for work, okay, that's a high paying labor charges. That's the reason why many of the laborers actually go to Kerala or other parts of South India to work. And during the COVID times, they have had real bad situations, they were not able to speak in the local language. And they, I still remember the COVID facilities had social workers who could interpret these people's versions of in their own local language, so that they can, because they were all patients, they were all suffering from COVID, and the social workers had a huge role to play. They have a role in the community liaison also, bringing about routine general contact with people, specific actions like creating a care package, facilitating community resources for the patients, children's education, job for a family member, basically the family member who has actually, died of a disease and, was in a government job or any other job, and then, the social worker would actually facilitate in getting that job for the next of kin. Okay, awareness generation in the community, that is like out of question, because they are the most important people who actually do excellent community awareness generation programs. Involving the family members in the care process, establishing long-term relationships with the bereaved family, education, awareness generation, everything actually comes under the purview of the wider role of a social worker. So in conclusion, the field of social work in palliative care is definitely newly emerging one, but not so new. The challenge is not only to demonstrate expertise in biopsychosocial assessment and intervention in advanced illnesses, but also to take a leadership role in development and research of new models of care and specific psychosocial interventions for patients and families. So with this, I come to the end of my slides. So I'll be very happy to take any kind of questions that might be there. So thank you so much.
Thank you, ma'am. Thank you so much for this wonderful session. So, if anyone has any doubts, you can ask, or you can use the chat box. You can also use your chat box for putting up the doubts. Or also any feedback.
Am I audible? Sorry. Good.
I would like to say the session was very knowledgeable and very informative. And you have covered all the aspects, ma'am, which I wanted to know. So I don't have questions now. Thank you.
Thank you so much.
Yeah, ma'am. Also, the same thing. It's a feedback from my side. So I am an MSW graduate and currently working as a counselor in Romila Palliative Care, Mumbai. And I totally work for the slums, especially in Dharavi regions. And I'm very happy that how the social work is being brought forward. In India, like social workers are stepping up right now. And I'm really glad that I could understand from your session, there are more, there are so many hidden spots where we as a counselor, despite having a MSW background, we as a counselor can actually bring in social workers' perspective into helping the patient psychologically. Thank you so much, ma'am. It was an amazing session. Thank you for the information. Yeah.
Thank you so much, and really good to connect with you. You're already working in a palliative care setup, and I'm sure that once you go back, you will encourage more people from the MSW background to come and join palliative care.
Definitely, definitely. Yes.
Thank you. Yeah.
Madam, good evening. This is Abhilash Praveen. We have recently started a palliative care in Tenkasi in Tamil Nadu. And I learned many things from your session. It was very informative. Thank you very much. And one big thing that I have taken away today is the team formation, the various stages of team formation, because since we started from scratch and we have no medical background and we started everything from scratch, Pallium has helped us with many inputs, and they're continuing to help us. But that I was always worried about how we could, form a team who will understand everything. So I was also having this, the doubts: how will the doctor be able to do correctly the palliative care, or will the nurse be able to do? Will the social worker be able to give the right, counseling and all those things? I was always wondering, and I think I've taken away that it is all an evolving process, and it is never an never-ending process that we always have to, nurture, and we have to continuously learn and adapt to with each other. Thank you very much.
Ma'am, I have one question. I'm so sorry.
Yes, please.
Ma'am, usually I'm a psychology postgraduate. Recently I finished. So whenever I wanted to do some volunteer work in the like psychology department around OPD, so they always said me no due to the privacy of the people. So we don't have such volunteer role, these things. So in our palliative care, how do we address that challenges, ma'am? or is it least treated, or we treat it but with the confidential? How it will happen?
Okay. So one thing that I want to, this is a very important question, and it is, it actually has been faced by many, not only by psychologists, it is also faced by many social workers also, counselors and social workers who come in to. So what happens is that you need to actually understand one important point of maintaining patient confidentiality. That is extremely important. I want to point out one thing here, since this topic has come up. In India, patient confidentiality is really, really jeopardized in many settings. Okay, so that is the reason why much of our data are being shared it gets shared over many other institutions. I mean, it goes to other countries also, and they make out so many research papers out of our data. This is quite unofficial, but I'm just talking just like a friend, I'm sharing this thing. But the point that you have raised is that, how do we maintain patient confidentiality? And first and the foremost, you have to be a part of this particular team. If you're not a part of this team, perhaps you will not have an access to give your expertise or contribute to this particular patient's care. Number two, to be a part of this particular team, I think you will need to have some little bit of background in palliative care also, because in palliative care, many things that we have learned in medicine, as a doctor I'm saying, something that I've learned in medicine, in my MBBS and in my special days, those things I have to unlearn them, unlearn and learn new things of doing the same thing for a terminal patient. Something which is applicable for a non-terminal patient, that particular process may not be applicable for a terminal patient. So it is similar. It is a similar thing for you. If I, let me just share with you one story of one of these MSW counselors who had joined us, and she was extremely enthusiastic and wanted to give so much to patient care. She had joined us, and she actually the patient was terminal. It was, I think, her second or third day, and she went to the patient, and she saw the patient was crying, and she just went on saying that, don't worry, everything will be all right. Everything will be all right. You will be better. You can walk again. And that thing is not going to happen. She was giving that person, that patient, some bit of false hopes. So, these things go wrong when you do not have a grounding of palliative care. Okay. That is the reason why I would suggest you first to be an observer in that particular team. Okay. Please be an observer for some reason. Just sit with the doctor or sit with the nurse or with the team or in that particular OPD and just, give them this particular body language, show through your body language and behavior that you're so interested to learn. That is a key to entering into this particular team. Okay. Let me also tell you from all these experiences that I have had, palliative care teams are also a little bit of rigid teams. And, they do have a notion that, out of this very fact that their patient would be hurt, they really don't they do not welcome many other people inside at the first go itself. So perhaps you will need to present yourself in that particular team while the doctor is talking, while the nurse is communicating, while they are doing that particular thing. You need to be an observer. Please be an observer, and you will notice that after a continuous means your presence in that particular team for maybe 10 days or even 11 to 15 days, 2 weeks, you are being perhaps accepted as one of the team members. This is also a kind of a forming stage for you, okay? Because you are the new member in the team without people knowing, okay? They already have a set team and you are the new person who's going to enter into that team. So your body language, your conduct, you need to be a silent observer in that particular thing. If I just wish that you practice this right from tomorrow, and you'll see a difference in their attitude, and that is where you will find a window to enter into the patient care process, and you'll be able to give your best. They will definitely ask for your help. And that is my experience, and it is absolutely practical that I'm talking. You may not find this thing in a textbook, but then I have seen this happening. So that's the reason why I'm saying this.
Thank you.
I don't know whether I'm able to satisfactorily answer your question or not.
Yeah, ma'am, it's cleared my doubt.
Okay. Okay. Okay.
So any more feedbacks or doubts? All right, so I think there are no more doubts or feedbacks. So thank you, ma'am. Thank you for your valuable session, and thank you, everyone.
Okay, thank you, Sanghamitra ma'am, for sharing us the valuable session, and thank you all for participating. Please share the feedback form of this section, which is given in the chat box and the WhatsApp group also. Thank you.
Okay. Thank you. Bye.
See you all in the next session.